So, thank you so much once again for sparing the time to come to talk to us. We're here in Washington, D.C., at the Duke University at D.C. My name is Tande Gadlamini, and I have Ambassador Wanda Nesbitt, who is willing to talk to us today about her experience in PEPFAR. And the time now is 10:48 a.m. So we're going to just shoot straight on into the questions that we have for our interview today.
Okay.
Welcome. Thank you very much. So our first question is really about starting off, and could you please tell us about yourself and your family? Where and when were you born, and where did you go to school?
I was born in Philadelphia, Pennsylvania. I have three sisters and a brother, and we grew up in West Philadelphia. I went to school, grade school, elementary school, middle school, high school, all in Philadelphia. And then I went to the University of Pennsylvania for my undergraduate studies. While I was in college, I did a semester abroad in Paris for a semester. I was quite good at languages, and so I was already pretty good at French. And through that experience, I decided to major in international relations. And a year and a half, 2 years after I graduated from university, I took the Foreign Service exam and became a Foreign Service officer. And I spent the next 38 years working for the State Department.
Oh, remarkable. It looks like all that you've done was working within the state and being a federal servant. So please tell us about your background after training. I know that you've done that kind of work with the state. So, I mean, if you can just relate like your work stretching from until PEPFAR time.
As I said, I joined the State Department in 1981. And so virtually all of my training, if you will, was with programs, activities related to my work for the State Department. For the first part of my career, I was a consular officer, which meant that I handled visas and passports in our embassies overseas, took care of American citizens who were in jail, who needed other kinds of assistance. I did a variety of assignments between overseas assignments and assignments in Washington, D.C. And I first encountered things relating to HIV and PEPFAR in the early 2000s.
Okay. Can you just explain how did you encounter those issues around HIV and PEPFAR?
What I vividly recall, it was not the PEPFAR program yet, but I was the number 2 official, the DCM, the Deputy Chief of Mission, at our embassy in Dar es Salaam, Tanzania. And the CDC, which of course I had heard of but never worked with, was sending their first officer to Tanzania. And it was part of my role as the DCM to help this officer get settled, become integrated into the community. We had never before had somebody from CDC assigned to Tanzania. And I thought it would be a fairly simple thing to do. And so I was quite surprised when I found that many of my AID colleagues were not at all enthusiastic about having somebody from CDC come and join them, and there were quite a few issues that I then had to deal with as the DCM in terms of helping the person from CDC get the information that she needed and be included in meetings that she should have been included in, and that kind of thing. So that was my first inkling, if you will, that there were these divisions between those two agencies. And she was coming to Tanzania, the CDC person, to work with the government on HIV/AIDS issues.
I see. So these kind of issues, were they related to HIV and sending the person down there, or was it something outside of HIV?
No, it was directly related to HIV.
Do you mind just elaborating what those issues were?
At the time, this was 1999, 2000. At the time, getting people to test for HIV/AIDS was extremely difficult. It was it was of course voluntary, and people had to choose to be tested. And my recollection, because I was not, I'm not the CDC person, so I wasn't deeply involved in her work, but part of what she was trying to do was to work with the Tanzanian government on things like, how do we get more people to be willing to be tested? And I remember that because I can remember even people in our embassy saying that they didn't want to get tested because finding out that you were HIV positive was like, being told you're going to die, because there was no treatment, there was nothing you could do.
I see. You have a lot of experience spanning different African countries, and some of it you've just said that you had to dispatch one of the officials that are supposed to start CDC work in Tanzania. So could you please just tell us about what you witnessed in the years building up into the announcement of PEPFAR?
I'm sorry, can you repeat the last part of that?
Can you tell us about what you witnessed in the years building up to the implementation of PEPFAR in the different countries that you were involved in?
I'm sorry, I'm not sure I understand the question.
Okay, so you've worked in Namibia, in Tanzania, and Côte d'Ivoire.
Côte d'Ivoire,
yeah.
yes.
So just as an official, but there's been HIV in Africa, either prior to PEPFAR or during the PEPFAR years. So I just want to understand, what was your experience or what was your take? How was HIV like before then, before PEPFAR was actually implemented or you were involved in PEPFAR?
I went to Tanzania in 1998, and I was there until 2001. So that was before the PEPFAR program. And as I say, people were very much aware of HIV and HIV/AIDS, and it was something that people were afraid of because there was no, at the time, there was no widely available treatment. It may have been the case, I don't remember, that there, for the very well-off who could afford to go to Europe, that they could get some type. But for most Tanzanians, HIV/AIDS was a death sentence because it was well known that people kind of lingered and withered away and died. I can recall some people in the government saying that they were going to funerals 2 or 3 times a month. That's how heavy the toll was from HIV/AIDS. But it was not a topic that we talked about on a daily basis in the American Embassy.
I see. So I guess what I'm trying to get at with this question was really to find out, if you're aware, if there were some kind of efforts in those countries even before PEPFAR that were being done by the different governments to try and respond to HIV, because this is people scared of HIV, but then was there any efforts at all that you're aware of that countries were doing?
I simply don't recall.
Okay.
As I said, Tanzania was the one place where I was posted overseas before the PEPFAR program was introduced, where HIV/AIDS was a known problem.
Okay.
And as I said, most of the discussion was around the fact that people were dying.
Okay.
I'm not aware of, I don't recall that the government had programs other than to try and help people understand how you get HIV and to encourage people to get tested. But as I said, a lot of people didn't want to be tested because they didn't see what benefit they would get from being tested.
Okay. So, we're going to get into your experience with PEPFAR. So what would you say is the highlight of the PEPFAR program, as far as you understand it, in terms of the achievements and shortcomings that you've experienced or you think PEPFAR has had?
I want to tell you about an experience I had, because I remember very, very vividly, sometime in 2003, I believe, going to what we called a mini Chief of Missions conference that was hosted by our ambassador in Kenya. At the time, I was in Madagascar, which did not have a big HIV/AIDS problem. But I was invited because I was part of that East Africa group. And I remember very distinctly a gentleman from Washington telling us about the PEPFAR program. And that was the first time I had ever heard of it. And what I remember was that he was very, very clear with us that this was not an AID program, and it was not going to be a USAID program. It was going to be managed from out of the State Department, which was almost unheard of, because the White House wanted to be very, very sure that people understood that this was a foreign policy initiative and not a USAID development initiative. And I remember that because we had a lot of discussions among the ambassadors who were there about how unusual it was to put the management of a program like that inside the State Department rather than in USAID or in Treasury or in some of the other agencies. I don't know that it had happened before. And the message that came across to us very clearly was they wanted ambassadors to be paying attention to this program. They didn't want us to leave the program to our AID directors or to anybody else, that they wanted us to pay attention to the PEPFAR program. And so when I got to a country where we did have a PEPFAR program, which was Cote d'Ivoire, and I went to Cote d'Ivoire in 2007, I went there with the understanding that a part of my responsibility as the ambassador was to not manage the PEPFAR program, but to stay abreast of what was happening with it and to make sure that I understood, to make sure that the money was being used for the things that were important to people in Washington. So I hope that helps to answer your question. Overall, I think that the impact that PEPFAR has had for people who spend a lot of time in Africa, the PEPFAR program is what made it possible for us to go from a situation where HIV/AIDS was a death sentence over the space of 5 or 10 years to a situation where HIV today is a chronic illness. And people, for the most part, if they are aware and if they are, if they get tested, if they take the medication, if you do the things that you should be doing for your own health, there is no reason for people to be dying from HIV anymore. And that is a sea change from where we were in 2000. And I think most people who are familiar, especially in Africa, recognize that it's the PEPFAR program that made that difference.
Yeah, thank you for clarifying that. I'm just going to go through trying to find to understand your experience, like from the different roles you had in Africa and the different countries. So I know we spoke about Madagascar and you were an ambassador at that point. And the first time you heard about PEPFAR through the missions that you had in Kenya, and that was mostly your first time. So I want to understand within that role, and as this gentleman had explained that PEPFAR was coming through and how it was going to be set up. What was your role? Was there any active role that you took back with yourself after getting this news and, when PEPFAR is being announced, and as an ambassador, was there any particular role that you had to make sure that when PEPFAR comes to Madagascar, is able to start up and it's able to do what it's supposed to do?
Part of the reason that we were briefed on the PEPFAR program was to make sure that we, as senior leaders in our embassies, understood what it was. It was a new initiative, and they wanted to make sure that we understood what it was. They also wanted to make sure that we would be able to explain to the host country government in the countries where PEPFAR was going to be putting a lot of money, which was not Madagascar, but that we all needed to be able to say, for example, if I was asked by the Minister of Health in Madagascar, well, how come Madagascar's not getting a lot of money? That I would have the information to be able to say, look, this is what the PEPFAR program is. If my recollection serves me right, I think it was initially 15 countries. And then I would be able to explain to him it's based on the percentage of the population that is HIV positive, and Madagascar doesn't fall within that range, and so that's why there's not a... So part of our role was to be able to explain to the host country governments where we were posted what the program was, why they were either included or not included, and to make sure that our own embassy people as well understood what the program was all about.
Thank you. It's very clear.
Okay.
It's very clear. Let's move on to Cote d'Ivoire now.
Okay.
So you're posted in Cote d'Ivoire as the ambassador in 2007, and it's an end of a devastating civil war, and then, HIV is like spiking in terms of infection within the West African region. I mean, how was the pandemic then when we got there?
It was a serious problem. It was a serious problem, but it was secondary to other things. As you mentioned, Cote d'Ivoire had been through a lot of political upheaval. They don't like the term civil war, so I try not to use that term, because there was never fighting in the capital between different factions. But there was a civil war in effect that took place. When I got to Cote d'Ivoire, the northern 2/3 of the country were under the control of a rebel group. So the central government didn't even have control of the entire country. They only had control of the 1/3 of the country that was south of a particular line. And that was the portion of the country where we were actually able to work and to carry out our programs, was the portion of the country that the government controlled. So we really didn't know what the status of the epidemic was in the 2/3 of the country that the government no longer controlled. Various agencies had statistics that were a couple of years old, but you couldn't be sure whether that was still the case. In the 1/3 of the country where we were able to work, the rates were pretty high. And I'm thinking somewhere between 15 and 20%, which is pretty serious. We had a very large, relatively large CDC presence in Cote d'Ivoire, which was a little bit unusual because typically you have a very large AID presence and a smaller CDC presence. In Cote d'Ivoire, because they had had this political unrest, AID had left and was located next door in Ghana. And they sent people periodically to Abidjan to see what was going on. So, in all honesty, we had a somewhat disjointed program because we had money that had been allocated to AID to do HIV/AIDS PEPFAR work in Cote d'Ivoire, but we did not have an AID representative on the ground in Cote d'Ivoire to manage that money on a day-to-day basis. CDC, on the other hand, had a long-standing relationship with the government of Cote d'Ivoire doing research. And so they were still there doing some of their research, some of which was HIV/AIDS related and some of which was related to malaria and TB and other types of diseases.
Okay, so you do say that there was a CDC, not necessarily PEPFAR when you got there in terms of the programs?
Exactly.
Okay.
Well, there was a PEPFAR program,
Okay.
about $50 million. There was a CDC presence, which was part of the, let's say we had 10 PEPFAR people. No, I'm sorry. Let's say we had 10 CDC people. Maybe 3 of those people were focused on PEPFAR, and the other 7 were doing other things. So we had a fairly large CDC presence, but it was not focused exclusively on the PEPFAR program.
Okay. Can you recall what was like the main strategy that PEPFAR was pushing through at that time? With those skeletal stuff, would you remember what they were pushing for? What was the strategy that was important?
I remember 2 things, because I will admit I don't remember. It was never the ambassador's role to get too deeply into, you know, you're not supposed to be a micromanager, and I was not a micromanager. But there were 2 things that we were discussing with Ivorians: mother-to-child transmission and male circumcision. And I remember that in particular because there were a lot of cultural issues in Côte d'Ivoire around male circumcision. And so it was a very difficult topic for our folks to even be able to discuss with the Ivorians. And they were very sensitive to having any type of public affairs messaging around the issue of circumcision. It was something that they were very anxious about how that issue was going to be addressed. But those were 2 of the biggest issues that we were working with the Ivorian government, was how to reduce mother-to-child transmission in particular. We were, if I remember correctly, still doing a lot of educational types of programs with young people, with prostitutes, with other identifiable groups of people who had high rates of HIV/AIDS.
I see. You mentioned that there was quite an issue with introducing male circumcision because it was culturally different to the Ivorians. I mean, maybe just briefly, and to the extent in which you were involved, how were you able to overcome that hurdle? Did they reject it outright, or were you able to eventually get them to accept?
I am not certain. During the time I was there, we were not successful in overcoming those hurdles. I don't know if that changed later on, but I can recall that in particular one of the doctors at CDC being quite frustrated because we thought we had an agreement with the Ministry of Health that we were going to have a rollout on, let's say, Thursday. And everybody was ready for it. And then we would get a call on Wednesday afternoon saying, oh, it's been postponed, or the minister's not going to be able to make it, so we're going to... And it was like, it just kept getting pushed down the road and pushed down the road. And somehow we felt that there were disagreements among the Ivorians. And some of them wanted to push it, and some did not. But during the time I was there, we were not terribly successful in overcoming that hurdle.
Yeah. There's the era of the COP. So was there a COP that you were responsible for during your time or not? When you were in Côte d'Ivoire?
Well, wow. When you said COP, I remember the term.
Yeah.
I don't remember many of the details.
Country operating plans?
Mm-hmm.
Yeah.
We did that. Mm-hmm. My role as the ambassador would have been to read the final product.
Okay.
And make sure that and make sure that I was in agreement with it.
Okay. All right. So at your level, there was no challenge that you can bring up to say you were
Not in Côte d'Ivoire.
Not in Côte d'Ivoire. Okay. Let's
Not in
move
Côte
right
d'Ivoire.
along if that's not relevant for Côte d'Ivoire.
Okay.
Oh, and then in terms of reporting as an ambassador, again, maybe it's different from from Madagascar. So you're now in Côte d'Ivoire. There's a small PEPFAR program, and was there any reporting role that you had outside just oversight role? To see documents when they're in the final states. I mean, you're liaising with the OGAC. How is that? Are you or not at all?
There was an ongoing dialogue, if you will, between Washington and the Africa Bureau and OGAC and ambassadors in the field. During the time that I was in Côte d'Ivoire, we got a PEPFAR coordinator. We had not previously had one. One of the things that I did after I got there was I brought it to the attention of people in Washington that we had what I consider to be a significant amount of money. $50 million is not a tiny amount. And nobody is signed on a day-to-day basis to make sure that the money was being handled the way it should. I was not concerned that the money was being stolen or mismanaged. I was concerned that we didn't know exactly what was happening. And so there was a dialogue, if you will, between particularly OGAC. And one of the things, they could not change AID staffing, but they did create a position for a PEPFAR coordinator, and it was filled. And about halfway through my 3 years in Abidjan, we got a PEPFAR coordinator. Okay. And the PEPFAR coordinator's role was to be the overall manager. And she worked with the AID people in Ghana and with the CDC people in Côte d'Ivoire and with the Ivorian government to make sure that we had a cohesive program, to make sure that, all the rules and regulations were being followed. She's the person who would have drafted the COP, and then the DCM would review it, and then it would come to me for a final sign-off.
Okay. So in terms of relationship and working together with the PEPFAR, at what level were you meeting or complementing, or it's just really like up in the hierarchy that you'll be involved and not necessarily reporting?
I would meet with the PEPFAR coordinator once a month.
Okay.
In the Ivorian government, I would deal with the Minister of Health, and the PEPFAR team, the CDC people, would deal with everybody below the minister's level. So I only would get involved directly, personally, when there was an issue that needed to go to the minister.
I see. Okay. So when you're in the host country, you need to have a relationship with the host country, managing diplomatic relations with them, and also supporting the different projects that are there or agencies that are there within the country. How was the state of the government in terms of like the public health system and being strong? What was your view of it? To be able to absorb, $15 million in a country that's poor is quite a bit. So how was your assessment of how the country was in terms of being able to absorb and use those kind of resources?
It was mixed. I will say that Côte d'Ivoire, before the civil unrest, had a very good health system. Do you know Côte d'Ivoire? Mm-hmm. Okay. I was going to say, then you know. They were the Paris of Africa. They had a very good health system, based on the French model. Well-trained doctors, well-trained nurses, and most of that infrastructure was still there. So where there were problems was primarily on the communication, the further from the rural areas to the capital. The Minister of Health in Côte d'Ivoire was a woman who had no medical training. She was the First Lady's cousin, but and they were like sisters, but she wanted very much to be a successful Minister of Health. And she tried very hard. I give her credit. She worked hard, and she was visible, she was active, but I sensed that there were issues within the Ministry of Health because of this arrangement, where, similar to our country, the career people are not always happy to have a political appointee at the helm. And so I think there were sometimes breakdowns in communication because of that. The one area that I remember being of significant challenge was transportation. In a country that has had civil unrest, and as I mentioned, we couldn't even go beyond a certain point. So getting things out to where they needed to be was always a challenge.
I see. So PEPFAR was primarily managing their own funds within the country, or were some of the funds being managed within the government? How was the setup, do you know?
No, it was all through NGOs. None of it went directly to the government.
Okay, let's talk about NGOs, because I was going to get into that, like from whose government now. Who are the other partners that were playing an active role in the implementation of the funds?
And I don't remember the names anymore. I really don't. I remember that we still had 2 or 3 big NGOs. And I'm not going to Save the Children or Oxfam might have been one of them.
Okay.
Something, not UNICEF. But I don't remember all the NGOs.
Well, it's fine. You don't have to recall
But I do remember that none of the money went directly to
government,
to the Ivorian government.
Okay.
We had some significant political differences with the government, and we had made a decision that we were not going to give any money directly to the government.
And then we know that one of the strategies of PEPFAR was working with faith-based organizations. Mm-hmm. Do you recall, how the setup was in Ivory Coast, in terms of how easy was that, and was there a very prominent role that they were playing?
What I remember is that among the NGOs that we worked with, there were faith-based organizations. I don't recall that it was a problem. So, I don't recall that anything was ever brought to my attention about it being problematic to work with faith-based organizations. Most Ivorians are fairly, religion's a big thing there, so it wouldn't have been a problem.
Okay. So now working primarily with civil society, which is the nonprofit, how was that experience in your view?
It was fine.
Yeah. Were there any capacity issues that were glaring which PEPFAR had to deal with to try to bring them up to speed? If you do have that experience, do share, but if it was lower in your roles and you didn't have to deal with that or heard about it, it's fine. We just also want to understand like the capacity levels then and now, the contribution that PEPFAR has had over the years.
I didn't personally deal with that, but what I can remember the PEPFAR coordinator talking about and telling us was that PEPFAR had the money to train people. And given the situation in Côte d'Ivoire, it was not difficult for our partners to find people who could be trained. part of the difficulty was keeping them because what would happen is we would train somebody and then the ministry would try to steal them away, or some other organization. The bigger issue that we sometimes dealt with was we were there, the EU was there was a UN element that was there. There were the French, of course, were there. And so coordinating among the various donors was a challenge. Because sometimes it seemed like we were all paying for the same thing. And some of the NGOs who were getting money from PEPFAR would also be getting money from the EU, and that was a big challenge in terms of capacity. And I know that was a frustration that the PEPFAR coordinator expressed, was that some of the same NGOs were getting money from multiple sources, and she wasn't always sure how they were managing that.
I see. In Africa, gender is a big thing. So did you recall any experience about gender issues that were affecting or having some kind of implication on PEPFAR programming?
Yeah, it's interesting you say that. I'm not quite sure how to articulate this. I can recall having discussions with my staff, with the PEPFAR coordinator, even with other ambassadors. December 1 is World AIDS Day, and there was always a big thing for World AIDS Day. And well over 80% of the people who would show up were women. And thinking back on it, I don't know that was the case in other countries, but I can recall thinking, especially in Côte d'Ivoire, that a lot of the people who were benefiting from the PEPFAR program seemed to be women, and this is not a problem. Mother-to-child transmission was a big thing. But I just remember being a little perplexed about where were the men. And so I think that there could have been issues going on within Ivorian society that I never delved into, about HIV being something that women were supposed to take care of, and maybe less so the men.
Gotcha.
Does that make sense to
you?
you?
Yeah, it does. It does. I mean, again, you are not, like right into the implementation, front line, so you might not have like the details of that.
But I would say certainly
that observation definitely speaks volume. There's a lot of layers into that.
Yeah, but certainly we didn't have any trouble getting women involved in PEPFAR programs. If there was difficulty, it was getting the men involved.
Okay. I think I'm going to transition to your experience in Namibia as now the PEPFAR coordinator.
Yes.
Right? And just confirming that, what we've read and all of that is relevant. So can you please tell us about your experience now being the PEPFAR coordinator?
No, I was never the PEPFAR coordinator.
Or ambassador?
Yeah.
To Namibia, sorry.
Yeah.
Or it's all ambassadorial roles. So you're in Africa, Madagascar, Côte d'Ivoire, and now Namibia. And PEPFAR has been going on. You have that kind of
time.
experience. Yeah. So at what state do you find Namibia at in terms of PEPFAR implementation and its programs?
Namibia was the most advanced. Namibia was one of the original 15 countries.
Yep.
Cote d'Ivoire, I think, was not one of the original 15. I think Cote d'Ivoire was added when the program expanded beyond 15. So Cote d'Ivoire had not been in the PEPFAR program as long.
Yeah.
I got to Namibia in 2010. And by that point in time, we, the United States, were already heavily involved in paying for, there was an extensive system that had been set up, and we were paying for drugs, for HIV/AIDS drug treatments that were being, distributed throughout Namibia. So there was widespread testing, there was widespread public education, like commercials on TV, radio spots. There was a very extensive public education program about HIV/AIDS. There was no reason for anybody who wanted to be tested not to be tested, and people who needed drugs were getting drugs. They had almost completely wiped out mother-to-child transmission. They were down to like below 5%. They were doing super well. They were really doing well. Namibia was like top 1 or 2, but basically in the top 5 of countries that had gone from, way down here to, they were way at the top in terms of success rates. So in terms of managing HIV/AIDS, they were doing extremely well. They were a success story.
Well, okay. So I'm just trying to find out more information. Like you're transitioning like from one country to another. How did that come along for you to be moved from one country to another country in Africa and doing this role? What's like your impression, and why did you become the candidate for that? Do you know?
Anybody in the State Department could probably tell you this, but it is typical for ambassadors to be assigned for a 3-year period of time. So I was in Madagascar for 2.5, slightly less than 3 years. I was in Abidjan for 3. So it was time for me to go on to another assignment. The Africa Bureau in Washington looks at vacancies for ambassadors, and they look at who might be a good fit for those places. And that process does not involve the person. You can't raise your hand and say, I'd like to be ambassador to Namibia now. But at some point in time, the Africa Bureau, obviously if they're happy with your performance in one place, they can propose to you that they would like to nominate you for this, that, or the other country. And obviously you can say yes or no. And then eventually the White House has to sign off on it. So after Cote d'Ivoire, the Africa Bureau asked me if I would go to Namibia, and I said yes.
What was the reason that made you say yes? You could have said no, right? I'm just interested to know. What was interesting for you to go to Namibia? Is there anything in particular?
It's personal. My husband wanted to go there.
Okay. Of course, because we want to document not only the professional story, this experience also has impacted you personally. We are going to talk at the end about how did it shape the person you are, that kind of experience, the career that you did, or maybe how you tell your kids how to go forward if you have kids or friends, because it's an experience that needs to be embedded in your life and it should carve certain decisions in your life. So I just wanted to find out that because, it's also important to tell the humanistic story of PEPFAR. Okay, so when you come to Namibia, then who do you find are the main role players for implementing PEPFAR? Is it any different from what you've seen in terms of Cote d'Ivoire and what was happening perhaps in Tanzania? How was that different?
It was very different. It was very different. I have said already that Namibia as a country was a success story in terms of how it was dealing with HIV/AIDS.
Okay.
The PEPFAR team within the U.S. Embassy was not a success story. Now, when I talk about the PEPFAR team, I mean all of the various agencies and entities that were working with PEPFAR money. I had mentioned to you that in Cote d'Ivoire, we had a larger CDC contingent and a very small, not really anybody from AID, and then we eventually got a PEPFAR coordinator. And we had about $50 million. The budget for Namibia was close to $100 million a year. Huge amounts of money. And both AID and CDC had significant numbers of staff to manage a program that big. I don't recall the specifics, but both agencies had at least 20 to 30 people. So they had very, and when I say 20 to 30 people, I should say, 10 to 15 Americans and dozens of local staff. Dozens. So both AID and CDC had very large staffs. And the two agencies did not get along for a variety of reasons. What this meant, because I was briefed on this before I went to Namibia, what this meant was that they were not coordinating well. So in a normal situation, if you have $100 million, your AID, your CDC, you would sit down and you would say, how do we want to spend this money? What are the government's priorities? Where are the greatest needs? And you would come up with a sensible plan that would say, well, we want to put this much to prevention. We want to put this much to treatment. We want to put this much into, whatever the various baskets are. That did not happen in Namibia. Instead, because the agencies could not get along, they said, okay, AID, you take half the money, CDC, you take half the money. And there was significant concern about the lack of coordination because it could result in duplication of effort. And so one of my mandates, if you will, or not really mandates, but one of the things I was asked specifically to do was to see if I could fix this. It was partly a matter of personalities, and it was partly a matter of kind of just making people behave professionally. We got a new PEPFAR coordinator, and we did a lot of work. So this was the one place where I can remember being involved in several sessions about the COP, because this was part of how we went about fixing the problem, was making CDC and AID sit down at the same table and with the PEPFAR coordinator, with me in the room, so that they would behave nicely, agreeing on what the contours of the program should look like. So that was my challenge in Namibia, was not quite so much the government as our own internal PEPFAR team.
this is what you arrive to when you get there, and then the program is doing well. It's interesting that it would be doing well, and yet you had this kind of scuffles going on internally. So post that kind of issue, managing it, I mean, was there any difference in implementation that was more successful, or would there be anything at all to mention around the effectiveness of dealing with that glitch?
I think one of the reasons the PEPFAR was successful in Namibia was because Namibia's population is actually pretty small. It's only 3 million. It's a country of 3 million people. So not that many people. And I would say the population where the rates of HIV were quite high lived in like the top third band of the country. So kind of a concentrated population where you could get to people and you could get things to them. Mm-hmm. So instead of trying to cover, millions of miles, right, it was a fairly concentrated population.
So logistically it was easier
so
to
I think
them.
Logistically it was easier. I think that the government, I give the Namibian government a lot of credit. They were quite serious in terms of their messaging on health issues. And I think they're, having been one of those countries where a lot of people died from HIV, there was a lot of emphasis put on how you get HIV, what you can do to make sure you don't get it, where to go if you get positive, and the government made sure, once treatment became available, that people would not have to worry about paying for it, that that it was very clear to people that if you test positive, here's what you do. And they made sure that the drugs were available. They made sure that, we had the money to pay for all of this. And so the government was in a position to be able to say these things. But nonetheless, they took it quite seriously. And so I think there was a very good campaign that was undertaken to inform people and to make people feel like it's normal. There was still, stigma was a big deal in Côte d'Ivoire. Not so much still in Namibia, maybe because so many people had HIV, but they had done a pretty good job of not stigmatizing in the same way that I saw in other places.
Okay, so government is quite vibrant and strong in Namibia. Do you have civil society being involved in the implementation as well?
Yes.
And how competent and vibrant were they?
Some were excellent. Really, really good. Usually it was the older in the sense of the NGOs who'd been around for a long, long time. And then there were some quite new NGOs, NGOs that had sprung up because there was a lot of PEPFAR money to go around, and we had very mixed experiences with them.
Okay, faith-based organizations, how was the role of religion in the response to HIV in Namibia?
Again, I don't remember it being an issue.
Okay. Let me see, how far along do we have to go?
We have 18 minutes left.
Yeah. Well, I guess the important thing to talk about now is the COP. But as you said, you are not really directly involved in the COP. but because of the issue that was in Namibia, you find yourself being dragged into that kind of space, and you make sure at least the first COP as you were coming in was done in a manner that was worthwhile and bringing all the different parties together.
Right.
So is there any experience you'd like to share about, now micromanaging that process, as you earlier on said that you don't have to micromanage, but in this case you were forced to micromanage. So how was that now involving yourself more in the development of the COP in Namibia?
Because we had had so many issues, because there had been a history, a negative history between AID and CDC in Namibia. When it comes, every mission is given budget targets that come from Washington. And one of the things that happened with Namibia was that we were told by Washington that we should plan for a cut. I think it was about $20 million. And of course, the instinctive reaction, I think, of any team is to say, well, we have to fight this. In the case of Namibia, we still had a lot of money in the pipeline. And because the agencies were not cooperating, I was reluctant to continue asking for more money. And so we accepted the cut. And then the discussion became, well, if we have $20 million less, how are we going to absorb that? And in terms of my role in the COP, this is where I kind of use the cut, if you will, to get the two agencies to come together to say, what are we paying for that the government of Namibia might be able to pay for or take over paying for? But then I left it to AID and CDC to come up with the answer. So that was my involvement in the COP, if you will, was to prompt them to think about things maybe in a different way. They eventually came up with the idea that we could ask the Namibian government to pay the salaries of the community healthcare workers. We had been paying their salaries. And ultimately, when it became necessary, I had a meeting with the president, I had a meeting with the prime minister to explain what was happening. And as I mentioned to you in an earlier conversation, instead of saying, oh, this is horrible, how can you do this to us? The president actually said, we can do that. We can do that. We have the resources. We will make it happen. And so they began to implement. And having this new element of we were going to stop paying the community healthcare workers, it actually gave the PEPFAR team something new, if you will, to focus on. Kind of okay, so if we're no longer paying for the community healthcare workers, how is that going to affect the rest of our program? How are we going to implement that? Where do we start? What order should we go in? Because it was going to be a phase type of a thing. So that was my role, if you will, with the COP. Was I never got into the details over how much money are we going to spend on this versus this versus this. It was more making sure that they were talking to each other about the things that they should have been talking to each other about.
Understood. Well, I was going to ask like the government's response, which you've already said that they were quite welcoming of the fact. So I don't know how much longer after this was implemented were you in Namibia to actually see now the transition. Can you just talk about the transition to see like you have withdrawn and you've cut out the resources and you're not doing this and that government is taking on. What was your initial impression or experience around that?
It was not it was probably 6 months before I left that the government agreed to take over paying the salaries. And so they were just starting to implement that when I was leaving. I will say, though, that I would be surprised if it did not go well, because this was just one of the things that the government was actually quite good at.
Or receptive at.
Yeah.
Okay. I'd like to talk about data.
Okay.
And data collection, because we know that part of PEPFAR, strategy and making sure there is diligence in the use of resources, there has to be a very strong data collection and reporting so that we can be able to tell how well it's going. So how was that done in Namibia to make sure that data was coming in? Were you involved like certain frequencies where they would share where the program is at?
I don't know. What I'm pretty certain of is that all the data came from the Ministry of Health. And I know for a fact that we had very, very good, we meaning the American Embassy, the PEPFAR, had very good contacts throughout the Ministry of Health and very good access to the ministry's data. The data that was not as, I won't say not as reliable, but was always a little bit shakier was from the NGOs. So for example, we could rely on the Ministry of Health accuracy in terms of mother-to-child transmission, because they would know exactly how many people had been tested in a public health facility. They would know how many people had tested positive. They would know how many women's children, if they were born not only in a hospital but in a clinic, and this is what the community healthcare workers were trained to do. So there was some data like that where you could be sure that it was fairly accurate because you knew how people had been trained to collect it and so forth. The data that we were never quite as sure about was data like, well, we know how many, let's say drugs. We know that we paid for X number of doses. We don't know whether people actually took them. So we know how many people were on medication, but we don't know what percentage of those people were actually taking the medication the way they were supposed to.
Gotcha. As we wrap up, just coming down to like your personal experience working in Africa and in this role with PEPFAR and as an ambassador with different host countries, how has that impacted you as a person, your career?
I dealt with the PEPFAR program in a number of different places. And I would say there were a couple of things. From a professional standpoint, I was frustrated sometimes that the intent of that it was so easy for people to lose track of the intent of the PEPFAR program and get into their own little fights and squabbles and agency, because I actually really liked the way the PEPFAR program was organized. I liked the fact that it was not a CDC program, it was not an AID program, and it was done that way deliberately, so that we would stay focused on the PEPFAR program is supposed to be about saving lives. It's not supposed to be about how much money your agency gets or how much money your agency gets or, you know. And so sometimes it was frustrating to me as an ambassador that that a lot of the people who were on the PEPFAR teams got distracted. And I wouldn't say that they forgot it, but that other things were sometimes a distraction. I think PEPFAR is one of the greatest things the United States ever did, not just in Africa, but anywhere, because it is the only program I know of that, as I said, took something that was a death sentence and made it a chronic disease. And we don't know how many millions of people are alive today because of the PEPFAR program, but we know that there's one hell of a lot of people who did not die from HIV/AIDS because of PEPFAR. And we know that we talk about AIDS in a different way because there's treatment and there's been successful programs and there's no reason for anybody to die from AIDS today.
Yeah. Okay, so thank you for that. One last question about, do you think there are any misconceptions that people are having about PEPFAR? I mean, within the US? Like people that they don't know what PEPFAR is and what it does, or wrong things that people know about it, you know, that you've heard?
We didn't really have time to get into it, but one of the side effects, I can't find the right word. One of the things that happens when a program is as wildly successful as PEPFAR has been is that people forget why it was there in the first place. And because we no longer have people dying in droves from HIV/AIDS, I think there are people, not just in the United States, but elsewhere as well, who can ask the question, well, why do we still need PEPFAR? Because people aren't dying anymore. And it's easy for people to forget that every generation needs education about how you get HIV. How do you protect yourself from getting it? What do you know? Why should you get tested? If you get tested, what treatments are available? How do you access treatment? And so there is an ongoing need for PEPFAR programs because it's not like HIV/AIDS went away. It's still with us, and people still need to know all the things that they needed to know. The other part of it, though, and I think as the example I gave you with Namibia, there are many countries that are in a different position today, some better, some worse, than they were 20, 25, 30 years ago. And so there are countries that may have needed us to pay for things. And it's legitimate to ask the question, do they still need for us to pay for X, Y, or Z, or have they reached a point where they can pay for it themselves? I think those are perfectly legitimate questions to ask. None of that suggests that, well, we just don't need PEPFAR anymore. But PEPFAR probably does need to adapt to a different era because we're in a different era now.
Thank you. I think I was just going to ask like a takeaway message to PEPFAR. I mean, it's still ongoing. There's reauthorization squabbles and all of that going on.
Right.
If you were to say something to Congress or these people, I mean, what would you say? PEPFAR to continue because this is the issue and what you feel is important about it continuing.
I think it should continue. If you want to save lives, PEPFAR has shown us how to do it.
Thank you so very much. I think that brings us to the end of our interview. Thank you for your time.
Thank you.
And I think we're just about.
Thank you very much.